Hello, my name is David Rosenblum, and I'm the Director of Pain Management at AABP Integrative Pain Care. We're located in Brooklyn and Great Neck, and my partners have multiple sites in Manhattan, Queens, and Westchester. Today I'm going to discuss opiate-sparing pain management. First of all, what are opiates and why do we want to spare them? Opiates are a group of medications that act on the endogenous opiate system in the body. These are medications that can blunt pain, and they come from the family of drugs that include heroin and morphine. The benefit of these drugs is they dull the body's sense to pain and pain perception, and therefore regulate the body's physiological response to pain. They can help decrease the increase in blood pressure, stress, and increase in heart rate, and of course suffering that occurs with pain. That's why we use them. That's why they're quite useful. We use these for post-procedure pain. We use them during surgery and in the cases of chronic pain from an injury. However, the downside to these medications are that over time the body gets used to them and you need a higher and higher dose to get the effect. In addition, patients can become addicted to the medication or dependent on the medication. Now, addiction is different than dependence. Addiction is a maladaptive behavior characterized by craving of the drug despite negative consequences. The patient will do almost everything in their power to get the medication. Whereas dependence means that if they don't get the drug, they're going to have a withdrawal syndrome or feel very bad. The other downside to these medications are the side effects that include constipation, urinary retention, and of course hypoventilation. And this is one of the ways that many people actually die. This is from the drugs. They usually die because they hypoventilate and they stop breathing. Now, pain management for years has been utilizing these drugs and still does, but of course there's a lot of concerns with the medications, and as most of you are aware, they're in the news all the time, and they're one of the most common reasons for death in the United States in this day and age. The reason for this is partially the fault of industry, the medical profession, and patient demand. And there were a lot of misconceptions years ago about the medications, misconceptions that include that pain medication the pain patients will not get addicted if they truly have pain. This is untrue. So because of all these problems associated with the medications, with the opiate medications, interventional pain or non-narcotic or non-opiate pain management is becoming more and more popular in our hospitals and in our pain offices. And the non-opiate pain drugs include non-steroidal anti-inflammatories such as ibuprofen, meloxicam, naproxen, or neuropathic pain drugs such as gabapentin or pregabalin, antidepressants such as nortriptyline and amitriptyline or Cymbalta, or duloxetine, which are drugs that can help modulate the body's perception of pain, and the alternative treatments such as acupuncture and cognitive behavioral therapy to help cope with the pain. But my forte and interventional pain management's principles basically entail finding the cause of the pain generator, which you can't always fix, but you can modulate. And I always tell my patients that I'm not a surgeon per se. I'm more of a fireman, meaning I'm going to find the pain problem and I might not be able to fix it mechanically by doing an operation, but what we can do is we can actually go in there, usually with a needle, and put a medication that will either relax the muscle spasms that occur as a consequence of the pain, turn the nerves off to break the cycle of pain, the constant bombardment to the central nervous system of pain signals, or put the fire out. And when I say fire, I mean inflammation or flare-up. Reduce that via a steroid or an anti-inflammatory. And these are the principles of interventional pain management. So in my office, when patients come in, whether it's Great Neck or Brooklyn, what we do is we actually examine the patient, look at their imaging, and we put everything together, the patient's complaint, their exam, and their imaging, and try to figure out, why are they in pain? What's bothering them? And it's not always that straightforward, meaning if someone comes in with back pain to the leg, and you get the MRI, there's a herniated disc on the MRI, that does not mean that that is the cause of their pain. Their pain can be due to other things that can mimic a herniated disc pinching the nerve, such as a piriformis syndrome, which is a muscle in the buttock that can pinch the nerve, the sciatic nerve, a little bit downstream of the disc herniation. So it's very important to make a proper diagnosis, and sometimes you might need to do a shot, and if it doesn't work, you then go to the other site of possible impingement or pain irritation or problem. So the idea behind interventional pain management is to isolate the pain problem, B, target it, and C, ensure that the patient gets adequate physical therapy and rehab. And this physical therapy and rehab may occur before you start treating with interventions or after. Often patients will see me after they try physical therapy and they're still not better. So a shot or an intervention is then indicated, and then we send them back to physical therapy in most cases. But along the lines of the opiate-sparing medication, we now have medications available to us that include longer-acting local anesthetics, and this can help reduce the need for long-term pain medication.